is bad prognosis and when to deliver. So now to identify fetal vascular. This is abdominal, uterine artery is there, uterine artery systole, diastole. Diastole is almost 40-50%. So no growth retard, no PIH, nothing. I am not worried with this picture. If it is less, I start getting worried. Because now the heart has to pump more for the uterine vessel to go. And when the heart pumps more, maternal tachycardia, maternal blood pressure will rise. So PIH will happen. And so we will look at the uterine and the umbilical. And then we look at the brain. Brain vessel should be 30% cerebral, very easy to pick up. So that middle cerebral is normal. If it is more, it is abnormal. Then we look at the cardiac decompensation or fetal death, ductus venosus and vein. So ductus venosus is M-shaped and the diastole should be 50%. If it is less, hypoxia is occurring. If it is zero, acidosis is occurring. Similarly, umbilical vein should be single straight. If it is pulsatile, then fetal acidosis is occurring. Okay, so that's what it is. So what vessel tells us what? Uterine artery tells us the trophoblastic invasion, which I explained to you. So it has to dilate to get more blood to the uterus. Umbilical vessels tell you placental resistance because impure blood has to come into the placenta. So if the resistance more, umbilical artery blood will not come to the placenta and the impure blood will collect on the side of the fetus. The fetal heart will have to pump harder, faster, fetal tachycardia will occur, fetal heart will fail, that small heart will fail and die. And ductus venosus, middle cerebral will tell you how the fetus is adapting, and the ductus venosus will tell you whether hypoxia acidosis is occurring. So very, very simple. So we have to look at all the vessels. You cannot look at only one vessel and say there is a abnormal fetus. So what happens? The first thing which will happen is the umbilical blood flow will decrease. So umbilical blood flow will decrease means umbilical, which was 50% diastole, will come down to 30% or 0 or reverse, depending on that. So increased PI and RI of umbilical. Okay. Then, or if it does not correct, absent end diastolic flow, zero diastolic flow. Then the brain sparing effect will happen. So brain will start getting more blood. So brain vessel which was 0.3 will become 50%. So brain vessel will become like umbilical will become brain. Cerebelloplacental ratio will get altered. That is what it is. Then it will redistribute. Still we are not correcting. Then the heart will get, then the liquor will reduce, fetal will lie still without any movements, fetal movement, fetal heart rate variability by NST will go. So this is happening almost 20 days before it could have been picked up. So if you're depending only on NST, it is just before fetal death. So if you depend only on biophysical profile, the fetus might die because of acidosis. Acidosis started occurring there. So this is how the frequency occurs. So the Doppler will pick up all these. The heart rate will pick up all the heart problems. The biophysical profile will be amniotic fluid and decelerations, which will be 3 weeks later. And if you can do the fetal acidosis measurement by fetal scalp blood sampling, that will pick up the multi-system failure. So this is the test which you apply for fetal well-being. And we have Doppler, non-invasive, very easy, quick, simple method to assess this. So if you do Doppler correctly, then 44% of antenatal admissions, 29% of induction of labor, 50% of cesarean sections, all this will reduce, and the perinatal mortality will reduce by 38%. So we'll be able to save a lot more babies if we are doing the Doppler at the correct time. And of course, look at the placenta. So normal, non-pregnant, systole, diastolic notch, diastole. Up to 11 weeks, it will remain like this. Then, if it goes absent, and the umbilical will remain without diastole. So 11 weeks Doppler is of these vessels is of not that much value. Only the ductus venosus is of value for chromosomal anomalies. As the trophoblast invades, the notch disappears, the diastolic increases. Okay, simple. If you see these wave patterns going like this, you're very happy. If you see very early no diastole, diastole appearing, diastole 50% in umbilical, very nice. We are very happy. And that tells you that the placenta is functioning well. So looking at the waves becomes very important. Now let's go one by one. Uterine artery will measure the PIRI, which I have told you how to. The machine will do you. If the notch has disappeared, diastolic is 50%. We are very happy with this wave. If the notch is there, diastolic is less. We are not happy with this wave. This mother is having hypertension, PIH, and growth retardation. Definitely. Because the uterine artery is not dilated. How to record a uterine artery? If you do an abdominal, get a partially full bladder. On the side of the cervix, you'll see the curved uterine artery, very simple. Put the cursor on it and you get a good wave. Transvaginal is much more easier because you are right next to it. Transvaginal, move the probe to the right or the left. If you're not obese patient, not able to pick up abdominally, do it transvaginally. And look at the velocity. The velocity is here around 60 to 80. It should not be very high. And the pulsality. And obtain 3 good waveforms and take a mean of all those 3 if you got to report the PI and the RI. So reporting ke liye. So this is how we do. We are scanning it. Abdominally, we have a full bladder, the fetus is there, the placenta is here. Then I put the color box. When I put the color box, I see the uterine artery, very simple. And then I put the Doppler and I take the Doppler to it and I get a wave pattern. So these are the steps for doing a good uterine artery and get 3 good waves. That's what you measure. So very simple, not complicated, not difficult at all for all of us. Remember, the uterine artery crosses over the iliacs. So sometimes you might get the iliac, you might put the Doppler on the iliac. When you put the Doppler on the iliac, you will get a systole, a diastole, and below the wave. So iliacs have triphasic wave pattern. Every artery has a different wave pattern. You cannot confuse it with the other artery. So uterine artery cannot be confused with iliacs if you know what the iliac. And a vein, of course, has a continuous pattern and not a systole diastole. So uterine circulation from this to this has to change. That is simple, and that means it will now low resistance, low impedance, ST and RI ratio are less, and end diastolic and notching have disappeared. If they remain, then it is abnormal. Very simple, understood. Uterine. So uterine artery will change from this non-pregnant to early pregnancy to after 20 weeks of pregnancy. These 3 other patterns you have to keep in mind with the uterine artery. So we will redefine the IUGR as I told you. It will be with any one of these now. So you can redefine with the CPR also, that the cerebroplacental ratio or uterine or the umbilical. Abnormal uterine artery at 12 weeks, and if you have the biochemical double marker, or now we have the pentamarker in the first trimester for placental PIGF and SFLIT, will tell you the early prediction of PIH at 13 weeks. So you combine the uterine artery along with the pentamarker or the quadruple marker in the first trimester to get a very early prediction of preeclampsia, growth retardation, and which baby is going to have later on. So at 12 weeks, 20 weeks, and 28 to 40 weeks, 3 Dopplers are very necessary in a pregnancy to predict whether this pregnancy is going on normally or not. Okay, clear? Now for PIH, maternal blood pressure in sitting position in both the arms with the BP instrument on the table at the level of the heart. Not like your nurse has taken outside, kaise liya usne, kya liya. Proper, if you want to predict mean arterial blood pressure, uterine artery, and the biochemical test will predict PIH very, very clearly. And the sensitivity, if you use all of this, is almost to the tune of 80% for preeclampsia early and late. So imagine if you can pick up early before 16 weeks, aspirin is the simple treatment. A lot of people say aspirin treatment, so why not start to everyone? Now you don't do that. That's not evidence-based medicine. Everyone does not need aspirin, only those where it is indicated, the aspirin. And aspirin also, starting after 16 weeks has no value. You have to start early and you have to get in the right dose, 150 milligrams per day at bedtime. That is the right dose and right time of aspirin, and not anywhere else and any time else. So uterine artery Doppler with biochemical. Then we come to umbilical, the next. The umbilical cord is very easily seen in the box. You put the Doppler, you get a systole and diastole. The diastole should be 50% as we've shown. So you'll get a sound, the uterine shuffle like that, sound also, and the wave pattern also. So this will tell you whether the placenta is working well or not, because it is going to allow impure blood to come into. If placenta is calcified, small, diseased, the umbilical artery blood will not come into the placenta, not purified. Umbilical blood vessel will have high resistance, and the umbilical will show less diastolic blood flow. So this used to be the only sign first which we used to take. So the diastolic blood flow should be 50%. And it should not be absent, it should not be reversed. I'll show you what it is. So normal, reduced, absent, reversed. These are the 4 patterns of umbilical blood vessels which you'll encounter in your practice, and very simple to see, very simple to do. Machine will calculate, but if you're seeing reversed, that means this baby is dying in next 48 hours. So immediate delivery is required, irrespective of the gestational age. And that again we have to decide, which we did in a consensus, which I'll show you just now. So abnormal uterine artery is decreased, absent, reversed. Very clear about this, very clear and very easy to pick up, very easy to do. No need to measure, no need to do anything, just look at it. Reversed means baby 70% of the placenta is not functioning, and this till 70% the baby can adapt. More than 70% of placenta damage, you will start getting reversed, and that means now the blood is, now this baby needs to come out. Then the middle cerebral. The middle cerebral has to be a normal uterine artery. So the resistance and the pulsatility has to be less than 2, resistance has to be around 0.7. If the diastolic increases, brain, why it is needing more blood? It is needing more blood because it is not getting oxygen. So it's dilating, fetal adaptation. So if the middle cerebral becomes like umbilical artery, reverse cerebroplacental ratio. And the umbilical becomes like middle cerebral, normal middle. So that you have to remember. That is what is cerebroplacental ratio. Very easy to pick up. You do a scan, put the color Doppler on, around the thalamus and the middle, you'll see the circle of Willis. Middle cerebral, anterior, posterior cerebral. Middle cerebrals are on the both sides. We'll put the cursor here. This is a power Doppler. This is a color Doppler. Power Doppler is single color. And once we put the cursor here, you'll get the wave pattern. Again, not very difficult, very easy to get with good machines. Normal waveform is less than 30. Mild vasodilatation is more than 30-40. Major vasodilatation, redistribution more than 50%. This baby will die because of blood congestion if you don't deliver. So that again, that's the middle cerebral telling you. So middle cerebral is telling you fetus is adapting to the less hypoxia or the placental malfunction. And this is known as the cerebroplacental ratio. The cerebroplacental ratio, 30% here, 50% umbilical. If 50% here, 30% here means that the cerebroplacental ratio has changed. Then that means there is a problem.